lung. That is how you will describe the parent organ. Now coming on to the pathology. So there is an area marked here. This shows Gons focus. Okay, that is the pathology which is seen there. Okay, so this Gons focus is seen in which disease? Then you can say it is tuberculosis of lung. Okay. Now these are the commonly asked questions, but after Gons focus, the next thing which will be asked would be the Gons complex. Then you would tell that Gons complex क्या होता है? So can anybody tell me what is Gons complex? It is Gons focus with what? Yes, that is the Gons complex. Yes, correct. Okay. Okay. After that, after Gons complex and focus are asked, then they can ask you the complications of this disease that you already know. TB has been covered multiple times. Okay. So first thing, describe the parent organ. Next is describe the pathology. Then Gons focus, Gons complex, and then complications of the disease. These things will be asked in TB lung specimen. Okay. Then the microscopy. In the microscopy, you see characteristic epithelioid cell granulomas. Now, how in your microscopy again, first you'll identify the parent organ. So how will you make out that this is lung? You will find alveoli. Okay. So when you see alveoli, these are blood vessels. So you will tell that this is lung. You can also find your bronchus and cartilage in it. Okay. So this is a zoomed in area of a granuloma. So whenever you describe the typical granuloma of tuberculosis, you will tell that it is a caseating granuloma. Now by caseation, you mean that there is a pink amorphous caseous necrosis in the center of the granuloma. Okay? That caseous necrosis is surrounded by Langhans type of giant cells. Okay, Langhans and epithelioid cells. Then the next question which could be asked could be the shape of the nucleus of the epithelioid cell. So your epithelioid cells have a slipper-shaped nuclei. Okay. The next question which is asked is the nuclear arrangement in Langhans type of giant cells. So in Langhans type of giant cells, the nuclei are arranged in horseshoe pattern. All right. So this causating organism and all mode of spread this all, Then next question could be various type of giant cells. So whenever you answer, you broadly classify your answer into categories. Okay. So to make it more defined. So first you'll tell that they can be pathological giant cells and physiological giant cells. Okay. So your pathological giant cells are, can anybody tell me? Pathological giant cells are foreign body giant cells, Teuton type of giant cells. Your Teuton type of giant cells are seen in xanthomas. Okay. Iris cells are not giant cells really. Okay. Pathological giant cells will be foreign body, tumor giant cells, Teuton type of giant cells. Okay. नहीं, iris cells नहीं बोलेंगे. फिर physiological giant cells will be your osteoclasts, megakaryocytes, and syncytiotrophoblasts. Okay, syncytiotrophoblasts is seen in the placenta. All right. Now, other granulomatous disorders. So, other granulomatous disorders, leprosy can be there. So, next question could be, what is a naked granuloma? Okay, so there are granulomas which are present with a peripheral cuff of lymphocytes and caseous necrosis, and there are granulomas which lack central cages necrosis. Okay, non-cageating granulomas. So those are naked granulomas. There is a whole list of diseases in which non-cageating can be seen, in which you can find leprosy and Crohn's disease is there. Then cat scratch disease is there. इसमें this is the most important thing which is asked. Okay. Now I'll come back. Okay. Yeah. So when you it's about the bonds focus and the bonds conflict. Okay? So how is the bonds focus formed? As the sensitization develops, the gray white inflammatory area is seen with consolidation. And bond complexes with the nodal involvement. Microscopy, you need to tell about the granulomas which are there. Then a very important question which is asked is biliary pulmonary disease. Okay, so biliary happens when the bacilli enter from the draining lymphatic to the venous blood and circulate back to the lung. Then small individual lesions, usually 2 mm. They are scattered throughout the whole of lung parenchyma. So there is one gross of miliary lung. This is the gross of miliary lung. So if you see very clearly, there are two very tiny white foci which are scattered throughout the lung. Here, 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 here. And the hilar lymph nodes are also enlarged and they are showing cavitation, okay, and they are matted. So this is a gross of miliary TB. So in this, we can ask you the site of primary infection. What is the type of post-immune response in this? Pathogenesis that you all pathology is seen as miliary TB. How will you identify the parent organ? You will tell there is a spongy organ showing a hilum, bronchioles are seen. So it is lung, and you can also see the pleura. Okay, so I'll come back to the gross again. This is a lung, this is the hilum, and this is your cavitation part, Bond's focus. This is again lung, hilum, and you can see multiple white dots, okay, white lesions here. This is miliary. This is the microscopic depiction of the granular alveoli, and then granulomas. Coming on to the next pathology, bronchiectasis. So what is bronchiectasis? It is dilatation of your airways. Usually happens in the lower lobes, okay? So your airways are dilated to around 4 times the normal size. Okay? And how do you identify that this is not normal? You can trace those dilatations up to the pleural surface. How do you do that? This is the cross of bronchiectasis. Now, firstly, again, you have to identify the parent organ. You will tell that this is lung. How do you identify that this is lung? By spongy organ and hilum दिख रहा है, bronchioles दिख रहे हैं, bronchi दिख रहा है. Okay. Now, you can see these red arrows. In this, there are holes in it. Okay. So these holes, you can trace them till the pleural surface. Alright. Normally, these holes should be present only in the vicinity of 2 to 3 centimeters to the hilum. But now these are till the pleural surface. Okay. So this is how you will identify that this is a specimen of bronchiectasis. Now you can be asked the clinical features of the disease. Clinical features are severe persistent cough, expectoration of smelling bloody sputum, dyspnea, orthopnea. Right? Common organisms associated, Haemophilus influenzae is formed in approximately half, and then Pseudomonas is found in 12 to 50%. This you should know. Okay? Then in microscopy, there would be intense acute and chronic inflammatory exudation with formation of the lining epithelium, and there will be squamous metaplasia which will be present. Okay? Then sometimes when inside these bronchiectatic foci, necrosis develops and it leads to formation of lung abscess. So the microscopy of bronchiectasis as per se does not come in your exam, only the gross specimen comes. But you should know the causative organisms. Grossly, you should be able to tell that the airways are dilated. Okay? Then you should be able to tell that normally bronchioles can be found in what area, and in bronchiectasis they are found in what area. These 3-4 questions are the important ones in clinical features you should know. Then there was a table in Robbins earlier which used to differentiate between bronchiectasis and asthma and whether it's now or not. Okay. Now coming on to your next specimen. Next specimen is that of emphysema lung. So the same thing again, you will identify the parent organ. You will tell that this is a spongy organ, lung है, hilum दिख रहा है. Okay. How will you tell that this is emphysema? You can find a bulla of the fluid surface. So it is not very clearly visible here, but I will just my pointer. इधर ऊपर लंग के ऊपर दिख रहा है. ठीक है? There is a bulla here. If you see very carefully, can be seen, not seen here that clearly, but इधर दिख रहा है bulla. So which part is most severely affected will be asked. What type of abnormalities in the PFT and complications? These are the questions which are asked in emphysema. Now, microscopy of emphysema is shown in your class, but it's not asked in the exam. So I'll just briefly go on that. So in emphysema, you will find dilated alveoli. All these are dilated and broken alveolar septa and dilated alveoli. And the pink thing which you find are, these all are inflammatory exudate. Okay. So parent organ identify किया lung है, pathology, emphysema हो रहा है. How is the disease classified? Now you can classify it as pan-acinar. Pan-acinar and centri-acinar, you should know which area is affected by which one. Okay, you can read this. Capital blebs or bullae are characteristic. Okay, there is a bulla in this set. इतना पूरी कहानी लिखने की जरूरत नहीं माइक्रोस्कोपी में. You should just know that there are abnormally large alveoli which are separated by thin septa, and those septa are also broken, and there is some fibrosis which is present. Okay. Then as I told you, you should know the types pan-acinar and centri-acinar and which area of the lung they affect. All right. Again, I'll just emphasize on this bulla. There is a bulla, और इस लंग में कुछ नहीं दिख रहा है. Okay, ये normal है. Now coming on to pneumonia. So your pneumonia, the slide is not there. It doesn't come in the exam. but the gross counts. So these are two specimens of pneumonia. So firstly, you will be asked, how do you classify pneumonia? लोबार लोब्यूलर में क्या difference होता है ये पूछेंगे. इसमें A और B there are two specimens. This is so A1 is lobar and this is lobular. You will be asked various stages. Various stages are congestion, red hepatization, gray hepatization, and resolution. You should know what is happening in what all. Okay, this is all your theory. You just need to remember this. So mainly gross, you should know that this is your lobar and this is the lobular. Complications you should know. So these are the important questions that are asked along with this. This is the commonly asked specimen other than TB. Now this is again a very important specimen. Why again the same story? You have to identify the parent organ, that is it's the lung. Xylem दिख रहा है, ठीक है. अब lesion दिख रही है, first section में क्या दिख रहा है? Gray white variegated appearing mass. So this is bronchogenic carcinoma. Then you can be asked on the basis of the location, can you type the carcinoma? So more often adenocarcinomas are present in the periphery of the lung, whereas your squamous cell carcinomas are present in the center or the hilar region. Then this thing will be asked about bronchiolo-alveolar carcinoma. Now it is known as adenocarcinoma NCT. It's a developed latest classification. So for all the lesions less than 3 centimeters in size, adenocarcinoma in situ is it is referred to as adenocarcinoma in situ. And these cells are they grow along the pre-existing alveolar septa, so it is known as the lipidic pattern. Lipidic carcinoma, now this is the pattern. This pattern can be seen here. SCC may it can be a squamous cell carcinoma, so it can be an exophytic growth. It can penetrate the wall of the lung, or it can grow along like a cauliflower-like growth inside the parenchyma. So basically, in bronchogenic carcinoma, you should know the classification of the lung tumors. Then you should know कि center में क्या आता है, SCC periphery में क्या आता है. Then you should know which carcinomas are associated with smoking. Okay. Then you should know about the paraneoplastic syndromes. किसके साथ क्या associated होता है lung carcinoma में, क्योंकि ACTH किसमें बढ़ रहा है. ये सारा issue. These are the questions. Then the next question which is asked, bronchogenic lung carcinoma is a metastatic lung carcinoma. So how will you differentiate between a bronchogenic carcinoma and a metastatic carcinoma on the basis of your class? If you notice carefully, in the previous class, the parenchyma was involved and there was a single growth, whereas in this class, there are multiple point-like lesions. Either well-defined lesions, and they are the tissue of these growth is different from the parenchyma of the lung. Okay. So this is metastatic lung carcinoma. Now, so this is important. You should know the difference between bronchogenic and metastatic on both. Now next is the lung abscess. Lung abscess means बड़ा से बुला होता है. You should know abscess formation कैसे हो गया. Abscess में क्या दिखेगा? Inflammation दिखेगा. You'll find pus. Then organisms associated with that again, Haemophilus. It can Klebsiella. Gram-negative bacteria are the most common in any type of infection in India. So you can find multiple abscess formation. बहुत सारे छोटे भी हैं और एक ही बड़ा सा. You should know the complications of lung abscess and causative organisms. That's it. Again, metastatic lung carcinoma, which is bronchogenic. ये A है lobar pneumonia, B है lobular pneumonia. Okay, this is your emphysema. Emphysema means grossly you'll find a bulla or a gleb on the head of the lung, okay, apical area. This is your bronchiectasis, in which you can trace the holes till the pleura. This is a KG18 granuloma, usually types of giant cells. Other granulomatous disorders, types of granulomas. This is miliary TB, छोटे lesions दिख रहे हैं. Now, you can confuse between a metastatic lung carcinoma and a miliary TB. But in miliary TB, first of all, ये देखो ये हाइलर lymph nodes दिख रहे हैं KG18, ठीक है. ये बाद फिर लंग के parenchyma में दिख रहा है. There is no well-defined disc-like lesion which are seen. Whereas in metastatic lung carcinoma, you can see a well-defined lesion. This is a Gons focus, very, very important. Okay, that is it. Anybody has any doubt? Can you please once again explain how to identify metastatic lung carcinoma? Yeah, I'll just show you. The metastatic lung carcinoma will show various coin-like disc-like lesions, okay, which are different from the parenchyma of the lung. So that is how you will identify that this is a metastatic lesion. Difference between miliary TB and metastatic. Miliary TB and metastatic are the same. Miliary TB में you will find metastatic lung carcinoma was a well-defined lesion. Those dot dots you were seeing were well-defined, and the parenchyma was different from the lung parenchyma. This is happening inside the lung parenchyma. And KG18 lymph nodes are also. Lung abscess. It is between miliary TB and disseminated TB. Disseminated TB will it will go to the whole body. It will disseminate via your blood supply to the whole body. A miliary comes back to the lung only after dissemination. It involves the lung. This is lung abscess. You can just find a cavity. There is cavitation and there is abscess formation. So there are multiple cavitations which are seen. How to differentiate between lobar and lobular pneumonia? So on gross, you can see that only one lobe, but broadly single lobe is involved. Lobular means the whole parenchyma is involved. So now I'll end the seminar. I hope the specimens and the microscopic pictures are clear. These are very important. TB to specifically, it will be for sure. It will be asked in your exam. TB to bilkul 101% will be asked. Ma'am, bronchiectasis. What about bronchiectasis? I show you the specimen again. Bronchiectasis may you can just a second. You can trace the dilated alveolar, you can trace the dilatations up to the pleural surface. This is how you'll make out that this is bronchiectasis. Or biliary TB again. This is biliary TB. Okay. So now I'll end this again. Thank you. Slide having four pictures. Here at least refer to the pathology and the slide which had 4 pictures is that of lobar and lobular pneumonia. So your A is your lobar pneumonia and B is your lobular pneumonia. No more questions? Thank you.